Today we're going to talk about a topic that is not always easy, but something that I think everyone needs to be aware of. Maternal mortality is a phrase that is used to describe the fact that unfortunately some women die during the period of time from the delivery for the year following the delivery. This is an epidemic that in some parts of the United States is actually getting worse rather than better. My guest today is Dr. Gregg Alleyne. He is a professor of obstetrics here at Drexel University College of Medicine. He is also the director of HIV and Women's Health and the director of global initiatives. On top of all of that, he is a wonderful doctor, a wonderful clinician, and a good friend. Thank you so much, Dr. Alleyne, for being here today.
Thank you for having me.
So one of the things that I wanted to talk to you about is I sent you this article that I saw where the rate of maternal mortality of the women dying during this period has doubled since 2010. Is there any sense of why this is happening?
I think we're in the early phase of analyzing this. The data that we have, it is brand new, and trying to make the associations of where this is coming from is challenging. It's hard to reconcile why this is actually occurring.
Well,
But we still have a long way to go. With the work that I'm doing now, it was a really enlightening event.
Well, when you talk about the work you're doing now, you're talking about the work that you're doing in going to Africa.
Yes.
Now,
yes.
In Africa, what is the main cause of maternal mortality there?
The main cause now is postpartum hemorrhage.
And that's
delivery.
bleeding.
It's bleeding after delivery and during the delivery. And it's pretty significant in many parts of many countries in Africa. And a lot of this is preventable deaths. There is a big initiative to try to address that. And as part of the work that I'm doing now in Africa with training workers who are maybe just traditional workers and midwives on how to deal with postpartum hemorrhage.
Because postpartum hemorrhage, it's my understanding, is something that we've pretty much dealt with here in the United States. Is
Correct.
that right?
Correct.
So
Yes.
when you go to Africa to teach them?
Yes.
And
yes.
I understand that you also are able to do it sort of via technology. Tell us about that.
Yeah, that's a big initiative. We have a distance education initiative. When we go and we teach, it takes us away from our day-to-day jobs. And the world is smaller. Technology is really, really, really good today, and that we are able to communicate as though they're right down the block. And we believe that education and training is the key. We can go over and do the work, but when we leave, things are still the way they were before we got there. Right. So it's our effort is to try to communicate and to be able to teach and educate from a distance. When you go to Africa, everybody has a cell phone. That was one of the most enlightening things.
Really?
Yes, everybody has a cell phone, and everyone has this technology, even in some of the more rural areas. And healthcare workers also have that technology. It's just access to some of the bigger institutions to get knowledge. Continuing medical education stuff is very rare. And training is not always consistent throughout different parts and different countries. So it's important for us to be able to give and to help to train and give the latest information to affect best change.
It's got to be really rewarding because when you go to Africa and you teach them to deal with this postpartum bleeding, that you can actually make a difference.
Yes.
Whereas here in the United States, when we
Yes.
see these statistics where it's getting worse in Texas instead of better,
Yes.
I think that the studies have showed that it was mainly due to cardiac problems and drug and alcohol abuse. Is that right?
That's correct.
Do doctors yet know how to counter that the way we know how to counter the bleeding problem?
Yeah, I think, this has been an ongoing problem. As an obstetrician, what I see is that we're practicing more high-risk obstetrics. Patients are more likely to have more comorbid conditions than we've ever had. So with the obesity epidemic, with hypertension, diabetes becoming more and more of a problem, it's complicating more and more of our pregnancies.
Right.
So is this the potential reason why this
Yeah.
happens? I think we need to look at this. I think we're in our earlier phase of looking at why we're seeing these numbers rise. Is it that we weren't paying attention, or is it that this is just patients are a lot more sicker than they've been before?
Well, and I think that that's a very important point that goes back to some of the things that we're talking about here, and that is that patients have a responsibility
Yes.
to themselves and their unborn children
Yes.
to take care of these things. So you're talking about hypertension, diabetes, obesity. Those are three problems that women really can do something to change.
Correct. Yes.
And is that something that maybe in the future there'll be more education? I mean, how do you how do you motivate women and potential future mothers to get on board with that?
Yeah, it's very difficult. I think the culture of medicine was less preventative and more interventional. And I think, I think there's a tide shift in how we're being trained and what we're going to be held accountable for, because it is more beneficial to compensate me for my services if I'm preventing certain diseases such as obesity, stop smoking, and things of that nature. Unfortunately, what happens in the way medicine is sort of run is that we have a limited amount of time, exposure, especially as an obstetrician gynecologist. I may see you once a year.
Right.
And we don't think that that's effective enough in making change in weight and helping people to stop smoking, which are two of the bigger ones that we believe contribute to most of the excess morbidity that we're seeing.
Well, and that makes perfect sense. And so the idea then, I think, is to bring in the community and get in support from your family and getting support from even online, perhaps.
Yes.
But really putting some of the onus on patients, because as you said, we want to prevent these problems for mothers and their babies.
Yes.
Do you think that it's something that can be fixed? You've done it in Africa. The work that you guys have done in Africa is amazing, and it's with the world getting smaller and smaller, that impacts us on a day-to-day. Do you think that you can make similar strides here in the U.S. with rates like what we're seeing in Texas?
We have to.
Yes.
We really don't have much of a choice at this point. We need to, and I think we're beginning to see those shifts in mindset from the medical field as well as our patients. And I think training doctors to think differently, training us to work in a group like, patient-centered medical homes where we work as a team.
Yes.
Instead of us, each of us has our part, and we're not communicating with each other. That's still a big problem in the medical profession, but we're beginning to see the shift in understanding that those types of approaches are going to have the best outcomes. I have a clinic specifically for HIV, which I do multidisciplinary care, and I have providers for infectious disease. I have a nutritionist. I have a multi-dimensional approach into their care, and our outcomes are really great. And this should be applied to many of the other chronic conditions that we're seeing, so that we can make a change by working as a team approach.
You have got it right on. And we've got to treat the whole patient and not just parts, and the patient has a role in that as well.
Absolutely.
Dr. Alleyne, thank you for being with me today, and thank you so much for all that you do for all those women out there.
Thank you for having me.